We still don't have a quorum yet. All right, thank you very much. Thank you very much. Good afternoon, everybody. Can you hear me? Can anybody hear me?
We hear you, Dr. Perlman.
That's good there, Christelle.
Yes, we can hear you.
Hey, Robert, I see you've joined the conference over there.
Yes, hi, Jeff.
Welcome.
Thank you.
All right, that's very good. I'll give a couple of more minutes, or 1 more minute before we'll start. And the guys asked for a talk on neuroimaging and the translation of images into practical points. So I'm not really going to talk about pathogenesis or treatment or anything, but just to look at an image. And I think it's very important that you have a basic understanding of what the images show, because what often happens is the radiologist reads the ultrasound, and if you're not really sure of what they're calling, or they may not be sure, then it's very hard to offer concrete information to families. And there are only 2 specific lesions that we'll go over that you can say with a fair certainty that the outcome is not going to be good. And that's based on years of looking at images, following babies up, as well as looking at neuropathology. So looking at the screen, we've got 13 participants, and we're going to go on our way over here. So the outline, we'll go over grading of IVH. We'll look at the relationship of grade to outcome. We'll do a case of severe IVH. We'll do a case of an unusual hemorrhage that we've had fairly recently. We'll talk briefly about post-hemorrhagic hydrocephalus and the ultrasound images, because it's a topic that we tend to gloss over without really specifically talking about it. And then we'll talk about a case of hydrocephalus and end with a few slides on PVL. So I think it's important in this neuropathologic specimen to really define what we're dealing with. So the blood originates in the germinal matrix, and you can see some extension down inferiorly, and then it can rupture into the adjacent lateral ventricle. And when it does that, we call it interventricular hemorrhage. And we grade it in part dependent on the amount of blood in the ventricle. Now, the original description or the grading of interventricular hemorrhage was based on a paper in 1978 by Luan Pupil. It was a CT classification where they could better define the amount of blood in the ventricle, so that if it was a small amount of blood, approximately 20% of the ventricular volume, that was a grade 2. And if it was blood filling the ventricle and with distension, that was called a grade 3. So the blood then starts off in the lateral ventricle and then migrates down through the 3rd ventricle to the 4th ventricle. So that is the spread. The spread will become important because you can see here that the aqueduct of Sylvius is a very narrow communication between the lateral and the 3rd ventricles. And if this clogs up, then the spinal fluid behind will start to increase. And it's like if you've got a drain and it clogs up completely, you'll get rapidly progressive enlargement of the ventricle. On the other hand, if the blood flows all the way through and you get hydrocephalus, as we'll talk a bit later. That is known as a communicating hydrocephalus. So this is a coronal view of the ventricles, and you can see these are the frontal horns depicted here in dark. And adjacent to the, adjacent to the ventricles over here is where the germinal matrix will reside. This is a coronal ultrasound scan, and you can barely see the frontal horns of the ventricles, best seen on the left in this one. The right is barely visualized. This is the periventricular region that we'll talk about a bit later. And it seems to be of normal consistency. So this is an example of a normal cranial ultrasound scan. This is a coronal section again, like I showed you on the previous slide. And you can see that the area of the germinal matrix is prominent. It's hyperechoic and more prominent on the left than the right, both sides. So this would be regarded or should be categorized as grade 1 interventricular hemorrhage, left greater than right. And if you look at a neuropathologic specimen, this is what it may look like, a small amount of blood. This is a bit more inferior in the just adjacent to the brain in the white matter. Now, this is a coronal section of brain. This is the germinal matrix on the left, germinal matrix on the right. And it's very hard to distinguish that from this hyperechoic area in the ventricles. So germinal matrix right, germinal matrix left, and you can see that there's blood filling the ventricle over here, and it's distending it. You don't have to be a radiologist to know that this will be a grade 3 hemorrhage. Grade 3 is blood filling the ventricle and causing dilation. You can have dilation without blood, as I'll show you a bit later on. And then certainly in a lot of cases, that could be white matter tissue loss if you don't have any ventricles. So it's bilateral grade 3. Now, remember I showed you that the blood will track down through the aqueductus sylvius, and you'll see it in the third ventricle. So this is involvement of the third ventricle, which is also dilated. Here you can see the temporal horns more posteriorly. So this would be defined as a grade 3 hemorrhage. Let me say, if something is not clear, you can stop me and I will re-emphasize a particular point. If you look at what we've just shown you, you can see that there's blood filling the ventricles. All right, it's grade 3. And you can see, I didn't really focus on this. This is outside or possibly outside the ventricle. If you look at the specimen over here, it's actually contained within the ventricular wall. This is where it becomes tricky. Or you're dealing with the so-called grade 4, which I don't like that term, or you dealing with just an expansion of the ventricle. If you look up here, you can see that it looks somewhat edematous. This is probably some of the edema that we see in the evolution to a large interparenchymal echo density. So this is a grade 3 interventricular hemorrhage. This is again a coronal section of brain. This is the left, this is the right, and you may see some deviation of the hemisphere over there. So this is, there's a lot of edema here, and so it's causing the right side of the brain to push across. You may call this small left germinal matrix hemorrhage, but on the right here, you've got a germinal matrix hemorrhage. And on this view, it's sometimes hard to distinguish that and the adjacent blood in the ventricle. You can see adjacent to the frontal horn of the right ventricle, you can see this increased echogenicity. Now, the question is this separate from this, or is this edema or whatever? And if you look at this specimen from this baby, you can see this very prominent clot in the right lateral ventricle. Oh, sorry. And you can see that. Is this part of the ventricle? You can make a cogent argument that it is part of it. Irrespective, this is a very large lesion that predominantly affects the ventricle. And whether on this ultrasound it's edema or not, that is why, as I'll show you a bit later, I don't like the term grade 4, because it doesn't describe what you're seeing on the ultrasound. And some of these babies may have a more favorable outcome than some others that I'll show you a bit later on, with much more extensive involvement of the frontoparietal white matter on that side. If we now look and you turn and you look at a sagittal view of the ventricle, you've got the frontal horns, you've got the occipital horns, you've got the temporal horns, and then you've got blood coming through the aqueducts of Sylvius and through the third ventricle to the fourth ventricle. These are the corresponding coronal images that one sees. So again, if you look at this, this is the frontal horn of the lateral ventricle. This very prominent structure is the choroid plexus. And you should look at this as a benchmark when you're looking at the white matter, because you can change the gain on the ventricle, and I can make the white matter look very prominent if I would like. This is the occipital, and this comes round to the temporal horn. If you look, you can see this is a germinal matrix hemorrhage. Some would argue maybe there's some blood back there. You'd have to look in real-time imaging to look at this. But essentially, I would call this a grade 1, and you could debate whether it's a grade 1 or 2. Whereas this one, it's obvious. This is really blood filling the lateral ventricle all the way through with ventricular enlargement. So this is clearly a grade 3 hemorrhage. Now, the important question is, what is the relationship of grade of IVH to outcome? And I've used a very simplistic term that I used in concert with my mentor, Joe Volpe. And these numbers may change a bit, but they are pretty much. So if you have a grade 1 interventricular, grade 1 hemorrhage, which is not interventricular, so excuse me, incident of definite neurologic sequelae, probably between 5 and 10%. If you have a grade 2, that goes up to about 20%. If you have a grade 3 hemorrhage, that's not, you don't see anything in the white matter, that's about 30 to 50%. And then if you have an interparenchymal echo density, if it's large, and I'll show you what I mean by large, 100% will have neurocognitive deficits, usually bilateral and usually a quadriplegia that happens. Now, it's important. There are two ways that you image babies. You image them early on if they have clinical signs. They may have seizures, or their antefontanal bulges, they become hypertonic. And if you have a grade 3 with interparenchymal involvement in that, the prognosis is not good. On the other hand, you may have a grade 3 with interparenchymal involvement may be small and you don't have any clinical signs, there the outcome may be far better. And this may be an overestimation when we talk about 80%. So what is the lesion that I'm talking about? This is clearly, this is your germinal matrix on the left. By the way, coronal view, just to remind you, this is blood filling the ventricle. And you can all see this very large interparenchymal echo density. We used to say if it's bigger than your thumb, that's a large interparenchymal echo density. We studied this very early on, you know, when I first started practicing neonatology. These babies died, or we provided comfort care. So we used to get autopsies. Now the autopsy on this side, this is left and this is right. And you can see the extensive nature of the hemorrhagic infarct that you see. The lesion appears to be more frontal parieto-occipital, but you can see it's very extensive on this image. Many years ago, we used to study the circulation of the brain using positron emission tomography, which is really, unless you're doing isotopes in an animal model, is the gold standard. And red and white is the highest blood flow, and blue and green is the lowest blood flow. So in this particular case, you can see that on the left, which is on this side, the lesion is seen more anteriorly and frontally, but you see extensive involvement of the hemisphere on that side. So that's why the size of the lesion that you see on ultrasound is very critical in trying to prognosticate a case. We studied subsequently many cases, but we published this in pediatrics many years ago. And all these cases had left-sided interparenchymal lesions. And one of the sidebars of this conversation, for reasons that are unclear, whether you're talking about stroke or whether you're talking about interventricular hemorrhage with adjacent involvement, the left seems to be involved more than the right, a ratio of about 2 to 1. And you can see in all these cases, the lesion was more frontal and anterior, but you can see in each case it was extensive, so that that becomes very important. As I was telling Liana yesterday, this is to me very important in your understanding, because this represents the corticospinal tracts as they start off in the motor cortex and work their way down. And you can see this is the white matter. You can see involvement of the leg, involvement of the trunk, the arm and the face. So if you have this large lesion that's sitting frontally, it should be intuitively obvious how you're going to really affect the motor tracts on that side. Often, although not well demarcated, you have involvement on the other side. So what I've tried to do in these series of slides is give you an example of you know, why looking at the image and knowledge of that based on a lot of prior work, one can certainly be very concerned and provide the parents with, I think, very sound options vis-a-vis. So this is the slide I just showed you, but this is another baby who had involvement within the white matter more posterior. And we did a blood flow study in this baby, and it was very symmetric. The point is that if the radiologist say to you, I've got a grade 4 hemorrhage, you don't have a clue what that means. They need to be descriptive. Is it frontoparietal large, or is it more posterior? Because you may not you may not affect the motor fibers as they go down, and this baby could have a normal outcome or a near normal outcome, or if there's potentially a motor deficit, it may be certainly milder than that thumbprint that I saw you. So just to remind you, if you have a large lesion, in my experience over the years, there was 100% poor neurocognitive outcome. And if it was localized, it may have been, I think this may be an overestimation. One of the things that I've learned over time is the important issue of brain plasticity and recovery. And we've seen kids with smaller lesions who've turned out to be just fine with a lot of interventions post discharge. All right, let's.
Perlman?
Yeah.
For the what is definite neurologic sequelae, and if they can't distinguish it from developmental outcomes, how do you know, for example, for the 10% and 20% in grade 1 and 2, that it's not sort of just related to prematurity?
I think that's an important question. I think when you have a grade 1 or you have a grade 2, it's more than likely related to the complications of prematurity. There's a very, I don't know whether it's infamous kid that we follow in the clinic who's about 6 years old, was in the hospital for God knows how long, had about 3 or 4 courses of steroids. His ultrasounds were all normal, and his MRI before discharge was normal. And yet at 6-year follow-up, he has severe spastic quadriplegia. He has hearing loss, and he has visual impairment. So that is, I think, even with the grade 1s, I know Dina saw a patient on Friday with a normal ultrasound or maybe a small grade 1 who has, an autistic spectrum issues. The point is that when you look at ultrasounds, even when you counsel families, you can say that the odds are in your favor that the baby is going to have, good neurologic outcome. But you always have to couch that with the premise that the outcome may not always be what you would expect it to be. But in terms of when you have a definite outcome, to me, the important thing is that you've always got to give the parents, if in that situation, the option to provide comfort care or to redirect to comfort care. Because importantly, parents don't understand that because the baby is maybe very cute looking, but has this devastating lesion, and they don't have any idea what the baby will look like at 3 years or 6 years when the baby has spastic quadriplegia or may have deafness in addition and other things. Been there, and families have said, if only I'd understood what you were saying. But again, it comes back to the important thing. You need to know what is being described. You need to look at it and say, gee whiz, this is a thumbprint. You go back to the literature, go and look at Volpe's book. He will take you through that. And the man viewed all the literature. So it's very important. Many years ago, because people didn't differentiate the size of the lesion, they clumped all these so-called grade 4s together, and people would say, oh, we've got this kid with grade 4 who's doing fine. And that's why you need to know, as the neonatologist, what you're looking at and what the implications are for the future. Because once they will get extubated, they will continue to survive and move on. And we'll come back to a case later on. I hope that answered your question.
Yes, thanks.
Oh, you're welcome. So case number 1, courtesy of Liana, X24 and 5/7 stat C-section, suspected placental abruption and fetal bradycardia. Didn't get betamethasone, and that's one strike. APGAR scores were 0, 4, and 4 at the respective times as indicated. Initial ABG 6, 7, 9. So when you look at this 24 and 5/7 week, never got betamethasone with initial pH of 6, 7, 9, you're worried. So let me see that. Oh, it's working. Beautiful. So this is on day 1. And a couple of things in this 24-week, you can see how smooth the brain is. You all the way around. This is the frontal horns. Germinal matrix looks pretty good. This is a small view of the cavum. The brain is so small, you can see the extraaxial spaces are very prominent. So this, again, is a more posterior view, and a choroid plexus, and it looks good. Now, somebody will say, oh, the white matter is very prominent. But at this stage, I wouldn't say anything. Going back, you can see how prominent the extra axial spaces are, the intrahemispheric spaces is prominent. Is this prominent white matter? You can say, yeah, it is, but we're going to have to follow that up. So let me stop that. And 24 hours later, the infant wasn't doing too well, and we'll stop. This is in 24 hours. And I think everybody can see that these frontal horns are very, very prominent. These are dilated. This could be the germinal matrix on that side. And now as you go a bit more posteriorly, you can see blood in the lateral ventricles. And you can see now as you go more posterior, it's filling the ventricle. This is the third ventricle. This is on the right. There's some blood over there. So you can see the temporal horns are very prominent. Okay, so you got blood in the third. You can see as we go more posteriorly, it's obvious. And this is even more posterior, and you can see the blood filling the lateral ventricle. So this is clearly a grade 3 hemorrhage, blood in the Sylvian fissure. I mean, not in the Sylvian fissure. Actually, it is. This is the Sylvian fissure, which is reflective of like a subarachnoid hemorrhage as one goes back. So just to take a look. Any questions on this one at this stage? All right, Liana did great there. Not for the baby, but good images. This is lateral on the left. Okay, and you can see this very large interventricular hemorrhage over there. You could argue maybe the white matter is increased. There could be distension affecting the venous return. Okay. I think that this was outside the ventricles. I've gone back and forth on this image, but can you see this? I call it the helmet sign. This is the third ventricle. If you were in the military, you would know that this looks like a helmet. It's
Dr.
filled...
P, I don't think we can see your cursor.
Oh, sorry. Thanks for letting me know, Jesse.
Now we can see it.
That's the third ventricle. And that I think is outside the ventricle. Okay. So again, the third ventricle that's filled with blood. Okay. This is the midline, and in retrospect, this is probably blood sitting in the cerebellum. We're recognizing, when others have recognized before, that the cerebellum is more involved than you can see usually on the imaging using just simply ultrasound. Okay, so all right, so grade 3. This is his MRI done fairly recently. I'll stop there. Can you see this hyperechoic area? It's actually, this is encephalomalacia on both sides of his cerebellum. And these are the ventricles that are dilated. As we work our way up, you will see that this infant, oh, I'm sorry, that's because I'm trying to be too fancy over here. So this is a cerebellar malacia, and then as we go up, blood involving the ventricles, and it's hard to discern whether you've got any specific. This is blood on the outside, old blood that is tracking there. This is the sagittal view. And one can see just the extensive malacia and involvement. Anything on this particular infant. So the important take-home points were the following. How at birth was negative, 24 hours later, it was extensive interventricular hemorrhage with dilatation, probably some involvement of the white matter that eventually progressed to post-hemorrhagic hydrocephalus, and he got shunted rather late than earlier as one went through. Case number 2 is a 2879 gram product of a 35 and 5/7 week infant, was an IVF pregnancy complicated by vasoprevia. The maternal MRI showed incidental finding of low signal focus in the left anterior cerebral cortex of the fetus, which was seen on 2 pulse sequences and deemed non-specific. C-section was due to the vasoprevia. Apgars is aligned over there, and the baby was initially on CPAP. Had his first image done at, I think it was 14 days. And this is a coronal section. And you can see it looks pretty clean, right? Again, pretty clean. And now as you go more anteriorly, sorry, the image I think was done on DevLab 5, you can see this increased echogenicity much more anterior. And you can see on this parasagittal view that you've got this echogenicity much more anteriorly, and there's some cystic changes in this particular lesion. And this is an SWC MRI image, which looks for blood. And you can see that you've got blood in this area over there, likely reflecting some changes to the venous system. Now, this is very anterior, and the question was, what is the cause and potential outcome in this case? So you've got this lesion very anteriorly on this coronal section, and it's very interesting. You've got deep veins called the medullary veins that course down, and at the head of the caudate nucleus takes a U shape and is thought to be the precursor for the interparenchymal echodensities that one sees with the severe IVH. But in this case, we had no IVH. It's very anterior. So is it more, you can either say more proximal branches that are draining this way that gave rise to that. If you look at this lesion and you think about where our white matter tracks are, it may not hit. You may be up here and it may just hit, just partially hit some of those those tracks. And because of brain plasticity, when this infant is 6 years old, you may not see any clinical signs. So this is not doom and gloom. I think you have to be cautious and inform the parents that you do have a change that happened. It's very anterior. It may hit some fibers that course down, but the baby may be normal from both motor as well as a cognitive outcome. So in this one, it's very critical that you follow these babies as we do. And we'll get a pretty good idea within 18 months to 3 years as to the outcome. Now, an important area is post-hemorrhagic hydrocephalus. And the progression of post-hemorrhagic hydrocephalus may be rapid or insidious over weeks. And the obstruction may occur at the foramen of Monroe or the aqueduct of Sylvius, resulting in a non-communicating hydrocephalus. And I pointed that out in the neuropathologic specimen that I showed you early on. Communicating hydrocephalus may occur secondary to an obliterative arachnoiditis in the posterior fossa distal to the fourth ventricle, and this is much more common. Just briefly, the big question is hydrocephalus deleterious? And if you look at experimental evidence, and I'm not going to go into this in depth, as a result of progressive hydrocephalus, you can get disturbances of white matter with early changes, particularly a decrease in myelin-associated enzymes and proteins. You can get cerebral vascular changes and attenuation of the major caliber of the cerebral vessels. And if there's one useful one aspect of Doppler is if you do Doppler of the anterior cerebral artery, you may see changes in the resistance, which will certainly precede the development of rapidly enlarging ventricles. And then with ischemia, you get all sorts of changes that accompany ischemia, changes in glucose metabolism, lactate, high energy phosphate compounds, etc. And then finally, you can get alterations in cerebral cortical neurons. Just to show you, again, our PET studies we did, this is a baby with hydrocephalus pre-tap, and we took off approximately 20 cc's in this baby, and you can see the marked improvement in cerebral blood flow. The purpose of showing these images is to show you that when you actually decrease or you remove the amount of fluid, you can certainly get changes in blood flow. So this is very important because we had a case recently that it could have gone the wrong way until we put the brakes on the neurosurgeons. So the natural history of communicating post-hemorrhagic hydrocephalus is shown in these series. So you see this, I'm fixated on this particular ultrasound image with this large interparenchymal echo density. And you can see the ventricles are starting to increase in size on both sides, the frontal horns. What's happened to the interparenchymal echo density, it's broken down, and you've now got cystic change. You even begin to see some cystic change on the right side, which you would have thought you may have seen an interparenchymal change over there. And then it gets even bigger over time. And interestingly enough, the right side is now less, the left side is less prominent than the right side. And you can see this dissolving maybe with additional cysts, and the temporal horns are getting bigger. And now if you go more posteriorly, you can see the size as it gets bigger, and then you see the cysts. So this is an evolving lesion over time. If you look at the lateral, this is left lateral, right lateral ventricle, and you can see that it increases. This is a communicating hydrocephalus. There are two things that are happening in this brain. One is that I think there would be evidence of an obliterative arachnoiditis, which is affecting the reabsorption of spinal fluid. So the ventricles are getting bigger by that mechanism. In addition, you've lost white matter with the cystic changes. So you've got a combination of the two, increased pressure and loss of tissue, which is certainly accounting for the changes that you see. This natural history of post-hemorrhagic hydrocephalus is very critical. So it can be rapid, it could be insidious over weeks, or a small percentage are late. We described a kid who had small hemorrhage and suddenly at 8 months developed rapidly progressive hydrocephalus, which is an enigma. You raise a lot of thoughts, but never can fully understand. If you have an obstruction at the foramen of Monroe aqueduct, it's a non-commuting, rapidly progressive hydrocephalus, and you've got to alleviate that. The communicating hydrocephalus, which occurs secondary to the obliterative arachnoiditis, is much more common. This is a classic paper from Hill and Volpe in 1981. And I'll orientate you to this. This is the head circumference intracranial pressure. We used to measure that with something called the LAD intracranial pressure monitor. So if you look at the ventricles, you can see progressive enlargement of the ventricles. But if you look at the OFC, it's only at a certain stage does this suddenly pop up. This is when we did a ventriculostomy and then a shunt. So clinical signs of evolving hydrocephalus, such as a full anterior fontanelle rapid, are less common and are usually seen with obstructive hydrocephalus. More commonly, it evolves in the absence of rapid head growth, and that's very important. You cannot rely on head circumference as the clue to when you may be in trouble. Remember, I told you that the one thing about Doppler, it can tell you when the ventricles are starting to impinge on the anterior cerebral artery. And so we should be getting those as the ventricles increase in size. And some of the possible explanations for this discrepancy include the relative excess of water in the centrum semiovale, the relatively large subarachnoid space, and the lack of cerebral myelin. And so serial scans are critical to follow the evolution of hydrocephalus. So you need to understand the natural history. In approximately 50% of cases, the progression usually ceases within a month. And then the remaining 50% is slow progressive that happens. This was the study that I mentioned to you before. They had 87 patients that they followed. There were 20 with rapidly progressive that you had to shunt. And then this is the group that is important. There were 20 and about 50% the ventricular mimically increased with raised intracranial pressure, and you had to divert. But in about 50%, it resolved over that first month. So case number 3, this was a 34 and 7th SGA male admitted to the NIC on CPAP, course complicated by direct hyperbilirubinemia. And a head ultrasound was obtained on day of life 16 for a decrease in crit. So on day of life 0 went from 49 to 26%. So again, courtesy of Liana, this is the ultrasound on day of life 16, and it's, oh my God, what is happening over here? And you can see the ventricles, frontal horns are big. And if you look very carefully, you can see, sorry, Jesse, you can see that there's increased echoes lining the ventricular wall. This you can see with blood that's been in the ventricle for some time, and in reaction, you can see that with meningitis. So let's just, so if we stop it there, you can see the frontal horns of the lateral ventricles, the third ventricle, the temporal horn. and there's an old degree of blood that one sees, just going more occipital. So there was clearly a bleed. If one looks at the sagittal to the left, you can see beautifully outlined, not for the baby, but for the image over here, the ventricles, which are dilated with blood in them. One doesn't know when the blood occurred, but certainly worrisome as you look there. And if you go to the right, you can see there's more blood on this side, and you can see that the ventricles, there's the blood over here that was missed before. I mean, not missed before, that it wasn't that clear on particularly the coronal. So looking at it a different way, this was the first image that was obtained on January the 1st. And you can see, as we saw in the movie, that the ventricles are back, the lining. This is a week later. And I think anybody in the audience can see that the ventricles are decreasing in size. And this is the third one compared to this. And this was on 126, 3 weeks later. It is amazing how it can resolve on its own over there. So you need to know the natural history. And I know Eric Lynn had to hold of the neurosurgeons over there who were ready to put in a shunt. We had to tell them to chill as we worked our way. And this is just the MRI, just confirming this was done on like 1/8, the ventricular dilatation. And I just showed a couple of the SWI, which looks at blood, and there was obviously blood in the ventricles. So the interventions for progressive hydrocephalus, you can put a drain, you can put a subgaleal shunt, you can do serial lumbar punctures, medication, Diamox, and there's a group in the UK who does certainly does fibrinolytic therapy. As you know, we don't have as many cases that we used to have many years ago. But I'll just show you again another example. If you take fluid off, this is before, and this was taking off 35 cc's, and you can see the marked increase in blood flow in this particular instance. Just a few more slides on periventricular leukomalacia. And again, I always like to start with neuropathology, and you can see these cysts in the white matter adjacent to the ventricles, and not well, but this was bilateral cyst adjacent to the ventricles. And this is a PET scan showing you the bilateral extensive nature of cystic PVL. And going back to our cartoon of the cortical spinal tracts, you can see how it involves both sides. And if you have this lesion, which is bilateral, this is one that you can say with impunity, this baby will have spastic quadriplegia. You know, the involvement of the of cognitive function is less precise, but you have to be worried. There are a couple that many of you have followed with me in the clinic. When you see this bilateral cystic PVL at the time of birth, it's not a good lesion. And ultrasound, if you know that it's around the time of birth, you'll see these are increased signal in the white matter, and you can see compared to the choroid plexus, it's pretty intense. If you look more posteriorly, you can see the formation of cysts. This is what we call a Swiss cheese abnormality, whereas the second form of white matter changes, you can see progressive lateral ventricular megaly. Third ventricle is not involved, fourth ventricle is not involved, And if you do an MRI, you can see that there's loss of the white matter in this particular instance. The enigma of white matter I show in this slide. The case history, 9-week, 815 grams, got 1 dose of beta-mathosone. APGARs were modestly low. Got 1 dose, I got surfactant once, went to CPAP on day of life 4. No blood pressure problems. Initial white count was 37,000. IDT was 0.5, 0.32 and 0.15. The initial CRP was 5.8. Was treated with 7 days with antibiotic. Placenta showed acute choreo and pneumonitis. This is a coronal section that we see, and this is about 10 days later, and you can see the cyst starting to evolve and the ventricles getting bigger. And you can see the changes on this parasagittal view of this infant. So as I come to the end of the slideshow, what I've tried to answer the question that the fellows in particular raised was, how do we use ultrasound to help us in really counseling families? And in answer to the earlier question, there are 2 conditions, in my opinion, where one can be pretty emphatic, and that's that large interparenchymal echo density and bilateral cystic PVL. For the rest, you have to be very cautious. I know Erica Lynn had a family who she counseled, and that family, if you had to tell that family there's a grade 1 hemorrhage, they may want to redirect care, and you have to work with them to tell them that is not doom and gloom by any stretch of the imagination. So I will stop at this particular juncture and be happy to answer any questions.
Trying to remember which family that even hits. I have so many, so many options.
Which one? I can remind you. I can bring up the nightmare, Erica Lynn.
That's okay.
Any questions, fellows? This was, you know, for you and others. Again, I think it's important to know, and for you to look at the ultrasound images yourself. And then if you're not 100% sure, get counsel or go back to the literature. I mean, to the box. Volpe's book is very explicit in these findings. If there are no questions, then I will stop and thank you for your patience and attendance.
Yeah, thank you. I think for us, I think just showing that chart again about the delay with grade 1s and 2s is always helpful. Because I know there's always controversy. You know, sometimes you'll say, oh, this isn't a big deal. But then when you actually talk to parents about it and explain to them what the germinal matrix is, like, of course, it makes sense that they may be at increased risk for delay. So I think that chart is helpful to keep in mind when we're counseling families too.
Sure. I think that's important. Just in terms of that, for those who are not aware, Erica Lynn raised a very important question. So that the germinal matrix is a precursor to both neuronal and glial elements. And by 24 weeks, those elements have migrated out towards the neuronal plate. So you can't say that all the elements are out, as I think Erica Lynn was alluding to. Now, because it's a transient structure, it's a very gelatinous region, as well as that the vessels that course through there are very immature. And there was a guy, Jonathan Wigglesworth, who was a neuropathologist, who said they were so immature you couldn't differentiate capillaries from arteries from venules, and he called it a vascular capillary rete. It's because of that immaturity and the poor support that they're much more vulnerable to bleed. And the 2 cases that I showed you of severe hemorrhage occurred in the context of women mothers not receiving steroids. And certainly if you can get 2 doses Certainly if you're using betamethasone, if you can get one course heading towards 2, you're in a better situation than just one dose shortly before delivery, because those capillaries haven't had the opportunity to mature, or not mature, but to get supporting matrix. Our work in rabbits suggested that there was a protein called glial fibrillary acidic protein, GFAP, that was upregulated and encapsulated these vessels, which provided some support to them. So your point is well taken, Erica, and I think the likelihood of injury at follow-up is very low, but you can never say, even with a normal ultrasound, that you may not have problems, as we've seen.
And then another thing we've been talking about recently, and I think Vivian just found the answer to this today, is just the right age to image at. I mean, you know, there's still plenty of germinal matrix left when you're born at 30 or 32, even 34 weeks. But we've just been talking about how we all have some variability in imaging and maybe trying to be more uniform about it. And I think, Viv, you're on here. I don't know if you want to share what you found with the AP, but it's much lower than I would have thought in terms of their criteria for imaging with sonogram. I think she found like 30 weeks or something.
Well, I wrote a paper many years ago, and I think it was 2000, on serial imaging using ultrasound for babies. I'll pull it out, send it around to you guys, because it became part of the practice parameter that neuroradiologists use for screening. And it's a tricky question, because if you look at that, that infant that Vivian had this week with a very anterior lesion, I think that was done on day 5. If you look at the little guy with post-hemorrhagic hydrocephalus, got an ultrasound on day 16. This was a 34-weeker. And the only reason that was obtained was because of a drop in the hematocrit. So it certainly, there's never an all or none. And up to 5% of term babies, if you scan them, will have choreoplexus or germinal matrix hemorrhage, even though the germinal matrix is not always there at that particular time. So it is a complex tissue.
Mm-hmm. Interesting. Thank you.
All right, guys. Thanks very much.
Thank you, Dr. K.
Anytime.